So what we have to do is engender trust within our clinicians. And this doesn't mean blind trust. It means we have to go to our technology and make sure that it does exactly what we say it's going to do, when it's supposed to do it, and that it's reproducible in some sort of boundaries, within some boundaries, and the clinicians get the data from it that they're expecting. This has a whole raft of different ideas behind it. The ideas of health technology assessment, verification of software, validation of the testing, and also some regulatory requirements. And it's a new field. We don't really have the infrastructures to develop the policies for taking the software along these routes. We've got to work with people outside the virtual physiological community, the traditional research community that we're working with, to ensure that we do the best possible validation of a verification of our software. For me, there's two types of data. There's data which resides in big databases, lots of accumulated data for lots of patients with different diseases and different disease profiles within a particular disease. And then we have the patient data, the individual data, and that has to be high quality. Quite a lot of the data that we get is good enough, and I think we probably have to express a need for really rigorous policing of the data that comes in. If something looks suspicious, then we shouldn't be using it. We should be going back, trying again, testing again, at least in the early stages. Eventually, in the long term, we'll probably have automatic systems that screen the data and identify those data points that are out of range, that can't possibly be valid for a particular case. So that's the sort of data, two types of data. One, accumulations of large amounts of patient data from all groups of patients, and then the individual data for that specific patient, which will then feed into the model. We do need to have a very clear strategy. The hospitals are best placed to start this process. They already have an eye to the security of the data, and they're very careful about maintaining potential confidentiality. We start there, and then with time we have to build secure systems, and we have to ensure in our own minds that the security of those systems is as best as possibly can be. So that's the way we would store our data. Look to the hospital IT systems and start from there, and then move out slowly. No big steps, no big risks. I'm sure they'll have a very strong interest, but again, we need to be sure that they're going to be guided by, so small steps and rigorous policing is what we need. So I see the digital patient in a number of different ways. Many clinicians, for instance, the imaging area, the radiologists, are used to interfacing with simulations, are used to opening up a computer package and seeing some sort of simulation there. But they're not directly interacting with the patient, so it's just the clinician and the screen in that context. When we bring the digital patient into the context of the actual patient, I would hope there would be some three-way interaction. So maybe some visualization that the patient can see, probably not too lifelike, not a complete representation of the individual. I think that would be quite frightening. But some way that you have an avatar and the patient and the clinician all working together. So you don't have a computer screen with a barrier between the patient and the clinician. I think that would be very disturbing for the patient and not very satisfactory for the clinician. So one of the frustrations for me is getting the applications into the clinic. At the moment we can get research funding for the technological developments and for a small amount of clinical trialling, and by that I mean just evaluating the software in a clinical situation. But what is really difficult is to trial it more widely with a larger group of patients. And the funding streams don't really accommodate that. Every funding stream has its own rules and regulations. They tend to ring fence the funding for certain purposes because it's a way of regulating what they're doing. You've got to put some boundaries on that. But for us, we need to have a funding stream which probably goes more into the healthcare side of things, but still enables us to do some limited technological development. So it's really cross-disciplinary funding that we need. The other gap, as far as I see it, is the regulatory side of things. In the future, I'm sure the industry will pick up that burden. But at the moment, until we have some realistic demonstrators, there is an element of regulation that needs to be put in place, which is not really going to be picked up by the companies at this stage. So until we have some proof of concept and some small models that are out in the clinic, then we're not going to get that industrial funding that we need. And that's, to me, where the boundaries lie, where the drawbacks are in the current funding streams. At one time we had some modelling concepts. We didn't have the computer power to deliver those concepts in a reasonable time frame, so that's clinically acceptable. We can't have a model which runs for 4 weeks. It's just not a viable situation. So putting those aside, there's plenty to do in those areas. There's lots of technological advances we've got to make. But really, there are a number of things that we've got to address that are more fundamental than that. We need a business model which allows the adoption of the digital patient. We're going to make cost savings, and there's no doubt about it. The digital patient will say, which will help us to predict, we'll say, which patients are going to benefit from which treatments. So it'll allow us to much closer to focus our treatments on the patients that are going to be get most benefit from them. So that's really important. So that's a cost saving. But the investment up front is going to be significant. So this is a policy decision. It's not a hospital level decision. There's got to be a buy-in from government, from the health service in general, right across Europe to enable us to start to get this technology into the clinic. The clinicians, I think, once they realise the benefits, will be quite excited by it. I don't think they can continue to work under the burden of the increasing information that hits them every day and the amounts of paper that they're still having to deal with. I think that's a real challenge for them. Are they sure that they're getting the best information to help them treat that patient? It will be at a touch of a button on a computer there, available for them. The assessment will be theirs, but the information will be there at the touch of their fingers, whereas at the moment they probably have to spend a lot of time seeking out all the information. So there are lots of opportunities here, but we need to look at the whole way that we produce and deliver healthcare in a very different way. And those decisions have got to be done at a very high level. So that's another issue for me. So computer power, yes, we have it. Models we're beginning to get, and they're beginning to come to the stage where they're useful. But then we need to deliver those into the clinic, and there are big hurdles to overcome in order that we can do that successfully. It's very exciting, but it's also very critical. Exciting because I believe that this is the only way that we can deliver medicine efficiently in the future. We also need to get the patients on board. I think many patients would benefit from having some technology which will help them manage their condition. Costs are increasing day on day. We just can't deliver the sort of service that we hope to deliver to the number of people that we have to deliver it to. So this is a very, very exciting point, and I think if we fail, then we won't have the health service that we should expect. So yes, it's an exciting point, but it's also quite frightening, because I'm not sure where medicine will go unless we manage to get these sort of technologies up front in the funding streams and in the development streams of the healthcare systems.